Thank you for joining us today. Some housekeeping before we get started. We will be using Teams. This is the first time we have used Microsoft Teams for one of our webinars. So pardon with us as we work through some of the newness of this platform for a webinar. If you want to, pop over to the chat. The chat is where we'll be placing our polls. And in fact, there's one there now. You may have to scroll to see it because it says, people have joined. But up at the top, it asks that question, how do you participate in QPP today? If you want to go ahead and answer that question, just to get familiar with the platform. In the meantime, let me talk through a couple of things. If you do want to ask a question, you can ask at any time. You can ask in the chat. Or if you want to verbally ask your question, go ahead and raise your digital hand. To do that, you will click the raise hand icon located at the top of the screen. It's the little hand and the smiley face. You'll click that and then you'll click the hand, not the thumbs up, the hand that you see over there on the far right. And Jason, who is on the call with us today, will unmute you or enable your microphone and you can ask your question. Additionally, there are some accessibility options that are not available in our normal webinars, and that is the ability to turn on live captions. Sometimes it can be hard to hear, or you need to turn your speakers down, but you still want to follow along. You can turn on live captions at any time. Okay, with that, let's go ahead and get started. So yes, this is a webinar about QPP 2022 proposed rule. My name is Aaron Higgins. I'm the data manager and IT strategist for Strategic Healthcare Partners. I have over 12 years experience working with the various and sundry federal quality programs back in the very early days of meaningful use and PQRS. I think there is still some PTSD associated with those two programs. And then it eventually evolved into QPP and MIPS as we know it today. I joined SHP in the spring of 2019, where I immediately was put to work helping practices and healthcare organizations really get their arms around these federal quality programs. And when I'm not doing that, I'm also helping our organization with our data analytics department. I manage data. It talks back less than employees do, that's for sure. So the topics we're going to cover today are the proposed rule for 2022. As you know, or maybe not know, CMS releases new rules every year for the quality payment program ever since the 2015 MACRA. And this year is no different. They are proposing lots of changes, and we'll go into what those changes are. And then usually November, December, they'll release a final rule just in time for us to do this yet all again and update you on what changed between the proposal and the final. So let's jump right into it. I want to stress that this is a proposed rule. This means that CMS will be making changes between now and when we get the final rule. Now, they make these changes based off of a lot of factors. They make changes based off of the feedback they receive directly from you all. They have internal discussions and pilot programs that they receive feedback on. So the proposed rule is just that. Everything that I am about to show you today could be completely different come November, December. Now, generally speaking, in years past, there have been a varying degree of changes, enough to understand what they're proposing, because what they're proposing is really where they want to get to. So while a proposed change for 2022 may not happen in 2022, you can expect to see it in future iterations down the line. And we've actually seen that happen a lot, where they have proposed such as a scoring change that was going to be really hard, and then they got a lot of feedback and they ramped down their scoring change only to bring back that same scoring change the following year. So that's the sort of changes that we see get scaled back, but this year is a little bit different. So let's first talk about some of the minor tweaks and changes that are coming to the program or proposed to come to the program. So This should be obvious on what this is. It's the clinician types. So not all clinicians, not all healthcare providers are MIPS eligible. CMS maintains a list of MIPS eligible clinicians, and that list is growing just a little bit. This year, they're proposing to add clinical social workers and certified nurse midwives. And that means that when you are an eligible clinician, you'll have to participate in QPP in some way. So whether it be through an ACO, through an APM, a MIPS APM, or through traditional MIPS. And again, one of those things about CMS proposes something and then it doesn't happen. The CMS web interface, which a lot of ACOs use to report their data and really large groups will use to report their data. CMS announced that they were going to be sunsetting it in 2020. And that was in 2019. And then in 2020, they said, oh, we'll sunset it at the end of 2021. Well, now they're saying it's going to not be sunset until 2023. There's just enough use of it and those people who do use it spoke very loudly that they want to make sure that this still continues until there's something else to replace it. So CMS is extending the life of the web interface. If you don't know what that means, that's okay. It doesn't apply to you. Another proposal is that typically CMS uses the prior year, full year's data to do a comparison against. They call that a baseline. And what they're proposing is that because the 2020 data is going to be skewed, we typically only saw really sick patients, the generally healthy patients either avoided care or they postponed care, or we've had to shut down our clinics for extended periods of time. CMS is recognizing that. So they are proposing that for 2021, so that's this year's data, will be compared against 2019's data, since they are at the moment feeling that that's going to be a better comparison than trying to compare it against 2020. As we all know, COVID skewed everything, and so their proposal makes a lot of sense. That being said, they are reserving the right to use 2020's data if they feel that it is complete enough. But at this point in time, the preliminary data and reading their detailed analysis as to how and why they reached this decision, they don't feel confident that 2020 data will be complete enough. Speaking of data completeness, they are raising the bar. Currently, for 2021, 60% of eligible patients, their data needs to be included in a report. Now, a lot of us using EMRs to do our reporting, this almost doesn't apply to us because 100% of our patients are seen in an EMR. We're reporting 100% of the data. But there are organizations, ACOs, certain APMs, as well as some clinics that are reporting their data on paper still, or collecting their data on paper still. And, there's going to be data completeness problems. CMS is raising the bar on data completeness. 70% of eligible patients need to have their data reported in 2022, and then that raises to 80% for 2023. Again, reading into the much more detailed analysis, they don't think they're going to raise it to 90%. It all depends on how things shape up. And finally, the complex patient bonus. I know a lot of specialty practices really rely on the complex patient bonus to help boost their score up. They are changing who qualifies as a complex patient. Essentially, you have to have 2 complex issues or greater in order to be a complex patient. They felt that the complex patient bonus was too generous, that a patient with a single complex item wasn't complex enough, so they raised the bar on that. So they're really aiming this bonus towards those patients or towards those clinicians that have those complex patients, because complex patients tend to be more expensive and time consuming. And so CMS feels that the complex patient bonus should really go to a much smaller set of clinicians. And what this awards is a 10-point bonus to your overall total score. Just a quick refresher on the score, and we'll get into the scoring changes here in the next slides. But your score is on a scale of 0 to 100. And so 10% of your score could be simply based on the fact that you're dealing with patients that are medically complex. So that is kind of a big change that I think is going to affect a lot of family practice and general practice, uh, just because the nature of the type of patients that you're seeing. They're also changing the number of complex patients. There's a lot more detail in the document, and for the sake of time, we're not going to dive into that, but I will be, before we are done here, uploading a copy of the slides and all the documents that I'm referring to in the chat, but we'll do that right at the end. Okay, so let's jump into scoring changes here. Because the macro law, which was written in 2015 and passed, it was written that it requires MIPS have certain thresholds based off of percentage by 2022. When they wrote that law in 2015, that was a whole 7-8 years away. And they figured, they being Congress, figured that by that time, everybody would be pretty used to it. CMS initially set out, if you recall, with some very ambitious thresholds, and there was a lot of pushback, particularly around the cost category. So for the first few years, the cost category was weighted to 0. CMS used that time to collect the data and understand where the benchmarks should be, and quality was also, and promoting interoperability. Those were the two heavy hitters. The IA, or the improvement activities, that's always kind of been on the lower side of all of the weights. But now, because of the way the macro law was written, CMS has to set the weights at these levels. So the quality category is going to be worth 30% of your overall score. Cost is going to be 30% of your overall score. Promoting interoperability will be 25, and improvement activities will be 15. Those don't change, but the biggest change is that the quality category is losing 10%, going from 40% of your score to 30, and cost is increasing its weight. And so that's going to potentially change the outcome for some of our clinicians, particularly those that don't have a lot of insight into what their cost measures might be. Now, with that weight change is they are changing what the minimum score will be to actually avoid a penalty. It's moving from 65, or sorry, from 60 for 2021. So that score is still good for this year. You need to score at least 60 to avoid your penalty. It's going to jump 15 points. You'll have to score at least 75 points to avoid a penalty. The exceptional performance is also moving up a little bit to 89. So you'll need to score 89 points or higher to get the exceptional performance bonuses. Now, it was originally slated, the exceptional performance bonus was originally slated to end this year. You were not going to get additional monies for doing better than average. They're proposing to punt that until the end of 2022. So hopefully it will survive the final rule. This is something that has made MIPS valuable to many people here on this call. Without that, I think a lot of people would be getting fractions of a percentage instead. And they're also proposing what they are calling small practice, or automatic small practice reweighting. And we'll touch on that here in a minute. Essentially, small practices are groups or virtual groups that have 15 or fewer eligible clinicians. So if you are in CMS's eyes a small practice, you are going to qualify for some automatic reweighting and some application if you want to reweight some of the categories. But again, we'll cover that here in just a moment. This is a nice visual representation of understanding how the weights are being redistributed between 2021 and proposed for 2022. As you can see, obviously the pie hasn't changed shape or size, but how it's being divvied up has. Now, I want to again explain this because this is probably one of my most frequently asked questions is, why are there performance thresholds and what does it mean? Why did I only get a 0.01% increase, or in some cases, like a 0.25% increase? Well, that's because per MACRA, MIPS has to be budget neutral. They can't add any debt to the national debt. Although, let's be honest, no one would probably notice if it did. So the losers, those that are being penalized, those that are below the 75-point threshold, in this case in 2022, their money that they are losing, so the penalties are then given to the winners. So those that are performing above 75 points or those that are performing in the exceptional performance bonus, they're getting all of their cash from the losers. So if you have not successfully submitted for MIPS or you're being penalized for MIPS, thank you. You are helping those that have been doing their good work to avoid their penalties. Now, as you can see here, there's a linear scale. If you were to say score 74 points, just missing that cutoff, your penalty is going to be very tiny comparative to somebody who's say at 20, only 20 points. Now at 18.75 points and below, that's an automatic 9% haircut. Doesn't matter if it's 2 points, 5 points, or 18.74, that is a 9% haircut. So this scale here is sliding down this way, and then we have this scale sliding upwards. Now again, these guys over here pay the winners. Now to achieve that budget neutrality and keep that exceptional performance bonus, which is over here, you get an additional performance bonus, and that comes out of those that barely have won. So if you are scoring 76 points, for example, and you're getting a 0.01% increase, and you're like, hey, I thought I was going to be getting a 2%. Well, that's because of the exceptional performance bonus. So your goal, if you are doing MIPS, traditional MIPS primarily, but if you're in an APM or a MIPS APM, you need to be scoring that 85 points or higher to achieve the full maximum incentive payment that you could possibly get. So your goal right now for 2022 will be to get that 85 points or greater. It is possible to do it. Now let's talk about small practices and the weight changes. Right now, and a lot of people may not know this, if you're a small practice, again, that's 15 or fewer eligible clinicians, you can request to have promoting interoperability re-weighted to 0. And what that means is CMS will go in and, or you have to go in and you make an application. You say, look, promoting interoperability is just too hard for my clinic to do. We're a small clinic. These are the reasons why. They will evaluate your application, and then they will reweight promoting interoperability to 0. What that means is that the improvement activities, quality, and cost will change their weights as well. Improvement activities will bump up to 30% of your total score, and quality will bump up to 40. Now, granted, this is the 2022 proposed weight changes. This could get tweaked a little bit, but I think this is going to stay relatively stable because this is typically how they've sliced it in the past. And you can also choose and apply for having the cost category reweighted if you're a small practice. And in this scenario, if you have both PI and both cost reweighted to 0, your improvement activities and quality are 50-50 of your total score. Honestly, if you're reweighting and you feel that this is really important for your practice to do the reweights, I don't encourage you to do it. And there's a couple reasons why. We'll talk about that here in a moment. But it does mean that you need to be performing really, really well in your quality. And it also means you need to be documenting exceptionally well for your improvement activities. Those that reweight are almost automatically audited. It's just be aware that you really have to have all your ducks in a row before you go in for the reweights. Now, right now, you do have to apply for promoting interoperability reweight. What CMS is proposing on my next slide here is an automatic reweight of promoting interoperability. Now, cost, that will continue to be an application where you'll have to prove hardship and not just being a small clinic. You're eligible to apply because you're a small clinic, but that doesn't guarantee that you'll get it. So let's talk about automatic reweighting. Starting in 2021, CMS started automatically reweighting the PI category for several clinician types, including certain ASCs, hospital-based clinicians, and non-patient facing clinicians. This makes sense. Hospital-based clinicians, non-patient facing clinicians, these guys don't have patients that they're seeing or needing to communicate with through a patient portal. A lot of times their hospitals are already sharing the patient data through an HIE or similar mechanism. A lot of the stuff that would apply to these clinician types in the promoting interoperability, it doesn't matter to them. Their patients aren't going to need a portal to see their records through the clinician. They're going to get their records through a hospital. So CMS announced for 2021 in the final rule, they're just going to wait promoting interoperability for these clinician types to 0 and for the hospital-based clinicians and the non-patient facing clinicians. That makes sense. Now for 2022, they are proposing that they will automatically weigh PI to 0 for clinical social workers and small practices. Again, going back to what is a small practice in the eyes of CMS, it is 15 or fewer eligible clinicians. And that's going to cover many, many of you who are on this call, or practices that this is going to cover that they have been doing promoting interoperability. Now, again, today, the option does exist. Today, you can go to qpp.cms.gov and you can go apply for a hardship exemption to promoting interoperability. You just fill out a form and typically they approve it. Now, PI started its life as meaningful use, going back to the dreaded 2-word phrase there that many of us are still shuddering about. That's where it started. And when MIPS came about, it got a few name changes, ultimately settling on promoting interoperability. But promoting operability is meaningful use. And many practices, large and small, of all shapes and sizes, have invested into EHRs to fulfill the requirements within promoting interoperability, including patient portals, connections to HIEs, registry connections, all of that. Now, that being said, it would be a shame for all of that to go to waste. And you can still participate in promoting interoperability. And why CMS is proposing an automatic reweight for small practices is because they have seen a large amount of practices that are 15 or fewer clinicians fail promoting interoperability. And they're not sure if that means it's too hard for these small practices, or maybe these small practices aren't able to check all the boxes and so they fail, because if you miss one measure, you fail all of your promoting interoperability. Or maybe they don't understand how to properly report their PI. It's not clear. So CMS is proposing for the next 1 to 2 reporting years to automatically reweight PI to 0. I think that's a mistake, and I think it would be a mistake too if you have successfully reported PI for you to stop doing it for that time. And here's why. First off, you get out of practice. CMS has said that this is a temporary thing, and within a few years, they're going to start requiring small practices do it again, and even eliminate the requested opt-out. So you may find yourself where you've turned off services or unsubscribed from something, and you have to spend more money to turn it back on or more money to retrain staff. I do not recommend that you do not report PI unless there is truly a unforeseen circumstance or some kind of technical reason why you can't do it. And you can still report it. So CMS did make it clear that while a small practice will automatically be weighted to 0, if they turn in any promoting interoperability measure, if they attest to any of the promoting interoperability measures, it will apply to them. So don't submit some of it and go, oh, well, I'll still be getting a 0. No, at that point you would get a 0 and it would be a bad 0, not the automatic reweight of 0. Okay, so let's take a quick break here as we launch a poll. So pop over to the chat. I'm going to drop a poll in there. And here we go. If you're eligible for the automatic promoting interoperability reweighting, are you planning on using it? Okay, see your results coming in here. Okay, great. Looks like most of you followed my advice. You're not planning on using it. That's great. Now, if you are planning on using it, use this again. If this makes it to a final rule, use the next couple of years to re-strategize and replan your promoting interoperability strategy. Perhaps there's something that's not quite working for your organization, or maybe there's just something that never will. And in that case, give feedback to CMS. Explain why you are not able to do promoting interoperability. Now, remember, they are not proposing to take away the non-clinician or the non-patient facing clinician exceptions, just the exceptions for small practices. That's a temporary thing and that will go away. So if your clinicians are not facing patients or they're hospital based, yeah, I wouldn't worry about that. It seems that CMS understands that that is something that's really important. So I'm going to go ahead and close this poll here. Thank you for answering the question. Great. Okay, and then we're going to do one more. With the increased thresholds, how do you think you're going to perform in 2022? Do you think you're going to meet or exceed the required 75 points? Are you going to get into exceptional territory? Or is it going to be a bit of a struggle to hit those 75 points? Or do you think you're going to be in that 9% haircut where you're not going to make it, that these changes are too hard for you to reach? So go ahead and fill that poll out. Okay, it looks like a few of you have answered that you're going to struggle to reach or you'll miss those required 75 points. And feel free to just throw this into the chat. A couple years ago, we did do a session on MIPS and how to maximize your score. Uh, if you want, we could do something like that again coming up here in the fall, kind of rehash some of those strategies and help you plan. If that's something you'd be interested in, just let us know. You could throw it in the chat if that would interest you. Or if you need me to, I can reach out to you and we can kind of talk through. I think everybody on this call, if MIPS is applicable to you, you should be able to reach that score. Okay, let me go ahead and close this poll out. Thank you all for your answers. Okay, great. Okay, before we jump into the next category, which is category changes, are there questions about the scoring changes, the thresholds, anything like that? And if you want to unmute, you can. Just be sure to raise your hand. We can enable your microphone, or you can drop your question right there in the chat. No? Okay, great. Either I've bored you all to tears and everyone's asleep, or I have answered all your questions. So let's talk about the category changes. The first one is, well, there's no new benchmarks. This is new. There's no benchmark measures that will be worth the automatic 5 points for 2 years. Sorry, I said that confusingly. New measures in the past used to be worth 3 points. So if a group introduced a new measure and CMS didn't have any benchmark data because it was a brand new measure, they automatically assign 3 points. Well, the problem with that is that people weren't picking them because they were only worth 3 points. They weren't worth the attention. So CMS has said we want more people to participate in these newer measures because we want to get these benchmarks. Well, so they're going to raise that to 5 points. So if you pick a new measure, and there's plenty of new ones, we'll cover those here in a second, those will be automatically worth 5 points for the first 2 years that they're introduced. This is their way of incentivizing people to start doing these newer measures versus relying on some of the old hat ones. Uh, I think they're right. And remember, you need at least 6 measures in quality. And I say at least 6, you can always go for more. And if you're doing new measures, it doesn't matter how well you're doing in them, although I would encourage you to do the measure, meet the requirements to help them create benchmarks, but you won't be quote unquote doing poorly. You'll be helping to establish a benchmark floor for those measures. Those are definitely worth looking at if they're applicable to your practice to get them and get those 5 points. Now, previously, it didn't matter how poorly you did on a measure. So going to line 2 there, the 3-point floor for benchmark measures is going away. If you do absolutely terribly on a measure, you'll get 1 point. So they're changing the scale. It was a 3 to 10 point scale. They're now moving that down to a 1 point. Now, this will be for measures, of course, that are greater than 2 years old. Now, some of the older measures still don't have benchmarks. And CMS is proposing that the 3-point floor get removed for those. And in that case, that would also be worth potentially 0 points. If there is not a measure and you're not doing well on them, forget about it. Now, that being said, the exception to this is going to be for those small practices. So if a small practice has a measure that doesn't have a benchmark or doesn't have good benchmarks, those will still be worth 3 points. Now, they're also changing the measures that don't meet case minimums. You used to be able to submit a measure, let's say a quality measure, and you only had 15 patients that measure applied to, and you did really well in that. So you would want to submit that measure. While CMS would say, well, that doesn't meet the case minimums, which is 20 cases. They would give you 3 points for that because you submitted it. Well, now they're saying no, they're not doing that at all. You won't, if you don't meet those 20 cases, you don't get the points. Again, little asterisk there, unless it's for a small practice, in which case you'll at least get 3 points. Now, in past years, prior years, if you submitted 2 or more high priority measures, you got an extra 2 points per measure submitted. CMS is going to remove that high priority bonus. You still have to submit at least 1 high priority measure, but submitting multiple ones no longer earns you points, bonus points. And then finally, the end-to-end electronic reporting bonus. That used to be a 1-point bonus that would be assigned to any measure that was reported end-to-end. So those are the ECQMs. If you're reporting an ECQM through your EHR or through a registry that pulled the information from your EHR, I'm sorry, that extra point that you got on that goes away as well. So what they're doing is they're making the quality category have fewer bonus points, but they are at least introducing the 5 automatic points for new measures, just to encourage you to try out those new measures, help them establish some benchmarks. So this could change your strategy in what measures you're choosing. Again, you can always choose more than 6. You can always submit more than 6, and that can help bump up your quality score. Now let's talk about the proposed new measures. And again, this will be attached as a handout towards the end. I'll upload it into chat. On table A, which that is on page 1380 of the proposed rule. And I will tell you, it sounds like a really daunting number. The proposed rule is big. You're not going to want to print it out. But that's because it is very detailed on measures, and measures take up close to half of the documentation. Some of these measures take up 4 or 5 or even 10 pages worth of information to explain how they are, how the benchmarks work on them, and that sort of thing. So don't be daunted by that page number. That's just where this list of the new measures and how they work break down. So these are some new ones. There's a total of 6 there that may be very interesting for y'all. The SARS-CoV-2 vaccination by clinicians. This is new, and they even mention this may be a relatively moot point in the future, and will most likely include boosters if we get to that point. So that might be something. It's kind of timely, kind of topical, worth exploring doing for 2022. Now, they are proposing removing 19 measures for removal in 2022. This is one of the biggest culling of measures that we've seen. In most cases, these measures have been deemed duplicative, or they're not achieving their original goals, or the organization that supports and curates the measure is no longer interested in doing so, and they haven't found a replacement organization to do it. But the biggest one, and the one I highlighted there, 317. 317 is a very popular measure across multiple different specialties. 317, for those that don't have their CQM numbers memorized, is the high blood pressure documentation measure. So it's a matter of, do you take the blood pressure? Is it considered high? And have you scheduled a follow-up with a clinician that treats high blood pressure, whether it be, a PCP or a cardiologist, or, fill in the blank. It was a very easy measure to do. CMS has felt that too many people are doing it, of too many different specialty types, that it's not really applicable to that area of care, and that it wasn't achieving their stated and hoped for goals and outcomes for that particular measure. So they are proposing removing it. If they don't remove it, they have a proposal in place to alter it drastically to make it less desirable to use. So if 317 is one of your go-to measures, which it probably is, it's probably going away in 2022. And then that's a big one. It surprised me when I saw that there on the list, but their reasoning makes sense. Now, there are 85 measures here that have substantive changes. And again, this list will be in the slide deck, which I'll upload. The ones that I've highlighted are ones that we have found that are very popular with practices. So running through that list, you'll want to take a look at what's proposed to be changed, and that starts on page 1596. They're in numerical order, so 001 is first, et cetera, et cetera, et cetera. The last page is 1694. So if you've reached 1695, you have gone too far. But this is everything that's proposed and the reasoning into why they propose to change these. Now, what is a substantive change? It can be something as simple as fixing a calculation error. They've done that in previous years where they discovered that they were over collecting patient population. So they're including people they weren't intending to include, which made the measure somewhat harder to achieve because it now applied to fewer people. So if any of these measure numbers are one of the numbers that you use, go check out the document to see what's proposed to change about them. Now, your EMR or your registry, they're looking at this too, and they're going to need to be changing things on their end to properly calculate. And again, these changes are for 2022. So if you're already set to use, for example, 317 for 2021, you're okay to do that. Just be aware, these are what's changing next year or proposed to change. They're proposing some new cost category measures. 5 new ones, in fact: a melanoma resection, colon and rectal resection, a sepsis measure, and 2 chronic condition measures, diabetes, and then asthma and COPD cost. So generally speaking, there is no easy way to see how well or what patients fall into these measures. There is, but generally speaking, you probably don't have it. You need a population health tool or a similar tool that can give you the keen insight of cost and what sort of cost measures apply to a patient. Most EMRs out of the box do not offer you that data, so you need a supplemental tool to help you identify that. Details about these new proposed cost measures can be found on page 849 of the proposed rule. Now, this first change for improvement activities makes sense. CMS had no method or mechanism in place to stop an activity outside of the rulemaking process, meaning that if they found that there was a activity that was not achieving its goals or could be causing harm, and not achieving its goals as in accomplishing the opposite of what they were hoping it to do, or something else, CMS had no authority to, in the middle of the year, say, no, this improvement activity is not going to be used anymore. Instead, the only way that they could do it would be at the rulemaking process, which is cumbersome and takes time and only happens once a year. And while they haven't necessarily had a need to suspend an activity before, they're trying to think through potential situations where that could happen. They did kind of sort of have that happen where they had an improvement activity that was tied to a program, a federal program that was sunset on July 1 of a year. So there was really no way to participate in the improvement activity, but the activity still existed. And it took almost 2 full years to remove it from the improvement activity catalog. So they're trying to avoid that sort of situation from happening again. And in some ways, they're giving themselves extra authority than what they previously had, but it makes sense. And if they were to suspend an activity, they would try to communicate that. They would use their listserv, they would use social media, they would send out information in newsletters. Of course, all the submission methods that exist out there, the registries, the EHRs, they would be told that the improvement activity no longer applies, and so they would remove it from their inventory. So this makes sense, and this could help if there was ever a situation where it was just bad and was causing harm and not doing good. So just be aware that there could be a new way that improvement activities are removed or suspended during a reporting year. Now, they're also changing and evolving the criteria for nominating in a new improvement activity. CMS wants better improvement activities, ones that people actually are implementing and truly changing the way they do their practice. So they have given clearer guidelines or better guidelines on improvement activities. And in the proposed rule, they are developing 8 criteria that a improvement activity will need to follow when it's proposed for nomination. Now, improvement activities don't necessarily need sponsors. You or I could think of an improvement activity, but you've been given a blank sheet of paper and say, here, create an improvement activity. They're now creating better guidelines that you would follow to help develop a new improvement activity. So if that's something that it would interest you, if this goes into effect for 2022, there will be guidelines published that you can use. So instead of a blank sheet of paper, you'll be given essentially a form to help develop your IAs. Speaking of new improvement activities, Appendix 2, Table A, page 1695 of the proposed rule has these 7 new improvement activities. All but 2 of them are medium weight. The 2 that are high weight is the create and implement an anti-racism plan right here, number 1. And then the promoting clinician well-being. These are both high. Now, in most cases, you only need to do 1 high-weighted activity. Depending on your size of your organization, you may need to do 2. These are 2 new ones. Go check them out. I think this is something that a lot of practices could benefit from, particularly the promoting clinician well-being. I think that's really important that we're looking out for our clinicians and helping to make sure that their mental health is where it should be so they can continue to care for patients the best way possible. Some of these other new improvement activities I think are great. Implementation of a PPE plan. In the light of the pandemic, obviously, a lot of organizations were caught unaware that previously their PPE just were gloves and maybe a surgical mask. Perhaps we need to be thinking about the next pandemic. And yes, we need to be thinking about those sort of disaster scenarios. So go ahead and read through these. I think these are great proposed improvement activities. A lot of practices could get benefit from them. And let's talk about promoting interoperability changes. They are proposing that the practices, no matter what kind of practice, have a immunization registry and electronic case reporting registry. Now, there are exclusions that still exist, such as if there isn't a registry that you can report to. There are some places within the country where there is no immunization registry. There is no electronic case reporting, either on the state level or on the county level. And those exclusions can be claimed. There are some practice types that can claim the exclusion, but this is a pretty big change for PI. If you're not currently doing this, go ahead and look at the proposed rule about this. I'm sorry, I forgot to put a page reference there for you, but you can just search for immunization registry and electronic case reporting in the PDF when I upload it, and that can tell you how you can claim the exclusion. Again, this would be a required thing to do in the promoting interoperability. There are different ways to fulfill this. And your EMR may even be prepared to help you fulfill this if this goes through. Provide patient electronic access to their health information measure. Boy, that's a mouthful for me to say. This would require indefinite online access to their EPHI. Essentially, if you have a patient portal now, it means you have to have a patient portal for them forever, as long as they are a patient at your clinic and you are maintaining their records. So previously, and thinking back to HIPAA on how long you have to maintain a record is 7 years, or 18 years plus 7 for those that are newborns. This changes that. For promoting interoperability, essentially CMS is saying you have to maintain these records indefinitely, and they have to be able to get to those records electronically indefinitely, such as through a patient portal. So that's a big change. Now that would be records starting as of 2016, which is the year that MIPS started. So any records that are before then could be archived. But that's something to think about in your archival strategies for your data is, can you archive the data and can the patient still get to that archive through a patient portal or some kind of online access? So that's something to put into your strategy on how big you let your databases get before you archive data and that sort of thing. Another new measure that has been introduced is the safety assurance factor for EHR resilient guides, also called SAFER guides, which is an annual assessment. There's documentation online on SAFER on how the assessment goes. It's pretty much a checklist. It's right up there with your HIPAA compliance assessment attestation, which you are doing, right? Where you will be going through the SAFER guides checklist, and you will have to self-attest that you have done it. It's important that you do it and you put it on file. And then they are modifying the prevention of information blocking to be more clear. There were some questions that have been raised through the rulemaking process in the past, so they've gone through and they have cleaned up some of the language, made it a little more precise, and then they have also aligned it with the other federal government initiatives, particularly with the Office for Civil Rights, OCR, as well as the Office of ORC. So the federal government initiatives around EHRs and information sharing, those have been very important to both the Trump administration and to the Biden administration. This is just clarifying that. Okay, enough of me talking here. We're going to do another poll. Let me get this launched. So what measure or activity changes are you interested in the most and would you like to learn some more on? So if you pop over to the chat, you'll be able to answer the question there. Okay, great. It looks like most of you are really interested in those new quality measures. Again, I would encourage you, and I'll upload the document here right at the end, to take a look at what those new measures are and those changes that are coming to the ones that you currently use. So let me close out this poll here. I promise you we're almost done. We're going to get into one more topic, and it's a really big topic. It's what I call the beginning of the end of MIPS. Now, in 2020, the MIPS value pathways, or MVPs, was an attempt to streamline the MIPS experience for clinicians. Right now it's very a la carte. You get to go in, you get to pick your measures, you get to pick your activities. You kind of get to choose how you participate in MIPS. In 2020, CMS stated that the goal of the MVPs was a way to help clinicians take the guesswork out of participating. They had heard a lot of feedback that MIPS was too confusing, too overwhelming. There were too many options. And so how could they make that an easier process and lower the ramp to participate? I expressed skepticism at that point that the only way to get clinicians to participate in MVP would be to make it mandatory. Sure enough, this year CMS has made it very clear that over the next several years, everybody who's in traditional MIPS today will be mandatorily moved over to an MVP. Now, they have suggested this timeline that we see here. Starting in 2022, they are going to still be traditional MIPS, but in 2023, they're going to begin offering the MVPs. So the MVPs, and we'll cover those here in just a minute, what those are, will be transitioned in through 2023 to 2028. And in 2028, they will be mandatory, the only way to participate in MIPS. So in a nutshell, they're pre-selected quality measures, improvement activities, cost measures that CMS defines as relevant to a specialty, patient conditions, or episodes of care. Essentially, if you are an MVP, you will only be compared against other clinicians in the same MVP type. Going back to that measure 317, if you do measure 317, every other clinician that does measure 317, you'll be compared against. Instead, what an MVP would do is that if you did measure 317 and you're in a MVP type that uses that measure, you'll only be compared against those other MVP types. This should help make it more clear on which specialty groups and types and patient types these measures really, truly, meaningfully apply to. So the first 7 proposed MVPs are going to be rheumatology, stroke care and prevention, heart disease, chronic disease management, emergency medicine, lower extremity joint repair, and anesthesia. That's a very small group. And as we can see, there's some specialties in there. There's patient conditions in there. There's a lot going on. So we're going to see the MVP list grow, and they are going to be using the feedback process to help develop these MVPs. There's a whole process we won't get into on how to submit an MVP. Now, to participate, some things will change. You'll have 4 quality measures instead of 6. You'll need to do only 2 medium weighted or 1 highly weighted improvement activity. Or if you participate in a PCMH, you'll get to participate in that and not have to do any improvement activities. You'll get to pick your cost measure, although they haven't said how many you'll have to pick. And then you'll do 1 population health measure. CMS has said that that will either be an improvement activity or a quality measure. It'll vary from MVP to MVP. And then, of course, you'll still need to participate in promoting interoperability. Now, how this will work is that a practice will register their clinicians for an MVP between the 1st of April and November 30th. Unless you're doing CAPS, in that case, you'll need to register by June 30th because that's when CAPS registration closes. So if you are a CAPS participant, your due dates will be a little bit different. Now, within the clinics, you will need to submit a subgroup if you have multiple specialties. So those that are multi-specialty groups, or maybe you're cardiology, but you have a subspecialty within your cardiology group, you're going to need to submit subgroups. And subgroups could have an entirely different MVP applied to them than what the rest of the group. CMS has done that so that way those providers that are subspecialists that don't have all of the measures applied to them, now they're going to be caught in that net, so to speak, that CMS is casting with the measures. So those clinicians that have only been doing 2 or 3 measures instead of the full 6, they're now going to have to do the full 6 measures because what applies to them as an MVP may be entirely different than what applies to the rest of the organization. So this could be a really big change for those groups that have those subspecialties that are really tiny or they have really low patient volume. They may find it hard to adjust their process for the MVPs. But again, unfortunately, we have about 6 years to get used to the idea and about 6 years for CMS to develop more MVPs. Okay, this is the last poll. I promise we're about to end here, and sorry, we're bumping up right against the hour. So let me ask this question. If an MVP is applicable to your organization before it is mandatory, so as we saw, they're going to start rolling it out in 2023, are you going to participate if it becomes available for you? Okay. I think everybody here is on that maybe train. I am too. It'll be curious to see how and if they incentivize anybody participating in the MVP before it's mandatory. I suspect that they will, because otherwise there's very little incentive other than perhaps fewer measures for you to have to do. So, okay, let me close that out. And as I have promised, I'm going to upload here. One moment. I'm going to upload a zip file. It's going to have all the handouts from today. If I can get it to drop into the box here. Okay, or not. I will email this out to everybody. I'll also have it posted to our website, but in there will be a link or all the documents that you need that we talked about today. It's going to have a copy of the slide deck. It's going to have a copy of the proposed rule, as well as all the proposed rule handouts that CMS has. So I will have that posted along with the recording of today on our website, which is www.shpllc.com/webinars. It's not letting me upload. I do apologize. I tested it earlier and now it's saying I can't share the files with you. So that's how we roll. So just stay tuned. I'll get it uploaded here later today. You'll be able to download it. But what you need to do next, so go ahead and read the proposed rule fact sheet. That'll be in there. It's about a 10-page document. It gives you a lot of the same information I share with you today, a little more technical. You can leave a comment, and I do recommend that if you feel really strongly about MVPs or you feel really strongly about promoting interoperability or anything about what's in the proposed rule, go ahead and leave a comment. And there's a link here. It'll be clickable in the PDF when I get that PDF uploaded, and you can leave your comments, which will change the way that CMS writes the final rule. Now stay tuned for the final rule. We should be getting that in November or December. CMS really knows how to ruin Thanksgiving for me. Usually they drop it the week before Thanksgiving, so I get to read through all of that over that holiday. Or if you need help, feel free to reach out to us. We can gladly provide you with a consult, answer any questions you might have. Shoot me an email, shoot Jason an email. Be more than happy to help you out. There are official resources that you can tune into too. The QPP Resource Library, which is located at qpp.cms.gov/about/resource-library, or you can call the help desk. Now I will note that the help desk typically doesn't answer a lot of questions about the proposed rule. They're definitely final rule type people, but feel free to reach out to them if you have a question about the current year. And then finally, if you do have questions, you can raise your hand and unmute. I can stay on a couple of extra minutes here, or you can drop your question in the chat. If not, you can drop off now and be sure to visit our website at shpllc.com/webinars. Alrighty, Allison, thank you. Thank you for attending. And I'll go ahead and stop the recording now.